I'm going to hand it off to Bill Lauerman. The first topic is lumbar disc herniation. It is the fourth ranked topic with a question weight of 9. In the past, they do like to ask about treatment of lumbar disc herniation, so a lot of the questions are focused on treatment. Other questions are really focused on basic science. So let's go into the first question. A 45-year-old manual laborer presents to the office with acute onset back pain that radiates to his right leg after carrying a heavy object. He also has mild weakness to ankle dorsiflexion on the right. What should be the initial management? His MRI is shown in figure A. So looking at the question stem, the things you want to identify here is that you have a relatively young person. He's 45-year-old with acute onset of low back pain and right leg pain after carrying an object. So right away you want to be thinking of lumbar radiculopathy. He complains of mild weakness with ankle dorsiflexion on that side. So mild weakness is common. It's not a surgical emergency when you see mild weakness. It doesn't concern me that much, and I feel very comfortable watching a patient who has 3 or 4 weakness for several weeks before I proceed with any type of surgical intervention. In terms of the distribution of the weakness, he has ankle dorsiflexion weakness. So that can be, the ankle dorsiflexion is tibialis anterior. That can be caused from either an L4 radiculopathy or an L5 radiculopathy. So here, we don't really know what level it is until we look at the MRI. On a different image, you'll see that this is actually an L4-5 disc herniation. So you see he has a fairly central disc herniation on the T2 sagittal images, and you can see his compression on the thecal sac. So they're asking, what is the initial treatment? So in terms of the treatment of lumbar disc herniations, you got to break it down into non-operative and operative treatment. For the purpose of this test for a lumbar radiculopathy, you really want to emphasize non-operative treatment, and it definitely should be your first line of treatment in the majority of the cases. So the modalities you want to use are rest, physical therapy, and anti-inflammatory medications. This should be the first line of treatment for most patients, as we mentioned. 90% of these patients will improve without surgery, and this has been shown in several studies, both old and new. Of course, most recently the sports studies, that although they show some improvement with surgery at 4 years, the results of non-surgical versus surgical treatment for lumbar disc herniation are pretty much the same. Another option is a selective nerve root injection. In my practice, people first go ahead with non-operative modalities, including rest, physical therapy, and oral medications. If they don't get better after 2 or 3 weeks and their symptoms are severe, then I'll progress to a selective nerve root injection, which is usually done through a transforaminal technique. Results of this basically show it does lead to lasting improvement in about 50% of the patients. This is compared to 90% improvement with surgery. And obviously the risks of nerve root injection are much smaller than surgery, so it really can't hurt to try this before proceeding with any surgery, at least in my practice. Going back to the question, we had a 45-year-old with acute onset pain. He had a little bit of weakness in his ankle dorsiflexion. What should be the initial treatment? Again, as we just said, you want to proceed with non-operative management initially for at least 6 weeks. This is the best answer: anti-inflammatory medications and physical therapy. The majority of you got that correct, which was answer 5. Some of you selected answer 1, microdiscectomy. You're probably thrown off by you had some ankle weakness, so you're thinking you had a neurologic deficit. Mild weakness is nothing concerning, and it's certainly not an indication for emergent surgery. Going back to the next question, you have a 40-year-old female presents with right leg pain localized to the buttock, posterior thigh, and lateral calf. In addition, she describes numbness and tingling in the dorsum of the foot. Physical exam shows weakness to EHL. 3 months of non-operative treatment, including anti-inflammatory medications, physical therapy, and epidural injections, failed to provide lasting relief, and her pain is still severe in nature. Her MRI is shown in figure A and B. What would be the most appropriate treatment at this time? So this is the same patient based on this MRI, and the only difference is now she has failed a first line of non-operative treatment. Her symptoms remain severe. They're affecting her quality of life, and she continues to have or has some weakness to EHL. So the big picture here is you have a patient with severe symptoms of an L5 radiculopathy that has failed non-operative management. It's affecting her quality of life. What would be the next step in treatment? And at this time, you'd be considering surgery. So at this time, I'm going to hand it off to Bill Lauerman, who's going to complete the remainder of the first part of the test Then we're going to hand it off to Brian Sue, and then I'm going to do the cervical questions in the end.
Right foot. Physical exam shows weakness to the EHL. 3 months now of non-operative treatment, including anti-inflammatory medication, physical therapy, epidural injections, have failed to provide lasting relief. Pain is still severe. Her MRI scan is shown in figure 5A and B, and what you can see is a disc herniation. Again, this is L5S1, probably a sacralized or partially lumbarized S1, but you can see a right-sided paracentral disc herniation. At this point, what would be the most appropriate management at this juncture? So the indications for laminectomy or laminotomy and discectomy, or microdiscectomy as it's often called, are persistent, disabling pain lasting more than 6 weeks that have failed non-operative options, including usually epidural injections. That's far and away the most common indication for surgery. Progressive and significant weakness, unusual in a disc herniation, but that might move up your timetable. And cauda equina syndrome, very rare, but obviously a surgical emergency. Good surgical candidates for microdiscectomy have, first of all, failed the test of time and 6 weeks of non-operative treatment, and they then have sciatica as their chief complaint as opposed to back pain. A positive straight leg raising test, and weakness or some neurologic deficit that correlates with the nerve root impingement that's seen on the MRI. The outcomes of surgery are usually very good. Probably 90% or more of appropriately selected surgical patients get rid of 90% or more of their sciatica. About 70% see back pain improvement, but some patients the back pain is worse. So back pain is unpredictable. And neurologic recovery is somewhat unpredictable as well. Only about 50% of patients get complete recovery of their motor or sensory deficit, and only about 25% will recover a reflex if it's absent. And again, it highlights that at 2 years and certainly at 4 years, the surgical outcomes and the non-surgical outcomes are about the same. So in this patient, the preferred approach after 3 months of not getting any better is a laminotomy and discectomy. If the patient didn't want surgery, could you refer to pain management? Could you do epidural steroids? You can't. You could. But the preferred approach at this point would be laminotomy and discectomy. And that is the original, should be the first operation for straightforward disc herniations, and certainly where the chief complaint is leg pain. Fusion is really not part of the primary surgical algorithm for HNP. A patient presents with a far lateral herniation of the L4, L5 disc. Which of the following findings is most likely to be present? Okay, so I've got a couple of diagrams here that basically just show the difference between a far lateral disc herniation, which you can see on the upper left diagram. You can see the far lateral disc at L4, L5. A far lateral disc herniation is going to get the exiting or upper nerve. So at L4, 5, it's going to get L4. A standard paracentral or posterolateral disc herniation is going to get the traversing or lower nerve roots. So in this diagram on the left at L5, S1, it would get S1. And here's just a couple of other diagrammatic representations of that fact. So an L4, L5 far lateral disc herniation is going to get the L4 root. L4 is involved in knee extension and ankle dorsiflexion. The numbness pattern that you might see would be medial border of the foot or maybe the anterior aspect of the leg. So of the options that they give you, and remember on the test, don't get caught up in saying, well, I thought this nerve root did that, or I thought this was the right answer. Concentrate on the fact they're only giving you certain options and select the best of the ones that they give you. And here, the preferred answer, the right answer is ankle dorsiflexion weakness. Ankle dorsiflexion is an L4 and L5 motor, basically. So ankle dorsiflexion weakness would be correct. The numbness would not really be over the anterior thigh. A number of you answered anterior thigh numbness. It would be over the anterior aspect of the leg or the medial border of the foot. And again, it would not be lateral foot numbness, and it would not be EHL weakness. That's an L5 motor. Okay, we'll talk about another topic now. A 60-year-old male has right leg radicular pain with hip abductor and EHL weakness. An MRI is shown in figures A through C. What is the source of this patient's symptoms? So the sagittal T2, sagittal T1, and then an axial T2 weighted image shows, you can see here, this cystic structure. You can see it a little bit right there. You can see it a little bit right there. But you see this cystic structure that emanates off of the L4, L5 facet joint. Synovial facet cysts, which is the topic in hand here. Synovial facet cysts are a manifestation of facet arthritis. They most commonly occur at L4, L5, although you can see them at any level, and oftentimes they're associated with degenerative spondylolisthesis. On imaging, you see an extradural cystic mass which arises from the facet joint and can intrude ventrally into the spinal canal, into the lateral recess, and into the foramen. Clinically, the patient will present with back and buttock pain as a manifestation of their facet arthritis, and they may present with symptoms of stenosis or radicular signs and symptoms. And the most common presentation, like we see here, is for the cyst to extrude into the lateral recess and get the traversing or L5 nerve root at L4, L5. Treatment options include non-operative treatment, which is basically just the treatment for spinal stenosis and facet arthritis. And if you're going to operate, the operation consists of resection, decompression of the thecal sac and nerve roots, and there have been several studies that have been shown that the best surgical results occur if you include a fusion in the treatment, because the primary problem is facet pathology, facet arthropathy, and if you don't fuse them, the cyst often comes back. So at any rate, the preferred response here on this imaging question basically is number 3, synovial facet cyst. A couple of you thought it might be an intradural tumor. It's relatively clear that it's extradural. You can see that the thecal sac is displaced by the mass. The mass is not inside the thecal sac, and it's not a disc herniation because it really just does not arise from the disc. It arises from the facet joint. Okay. Patients with symptomatic spinal stenosis treated with surgical decompression compared to those treated non-operatively have what clinical outcomes? So in spinal stenosis, the indications for surgery are persistent pain, typically leg pain, lasting more than 3 to 6 months. Occasionally you see a progressive neurologic deficit. This may be represented by weakness or bowel or bladder function, relatively uncommon, and the patient should have failed some attempts at non-operative treatment. And the results of surgery have been studied in detail. Generally speaking, a number of studies, including the most important, which is the SPORT trial, which is a testable literature reference, basically. The SPORT trial has demonstrated improved pain and improved function with surgical treatment in spinal stenosis versus non-operative treatment at 2 years following surgery in the SPORT trial. Other facts about surgery include that the most common cause of failed surgery is recurrence of the disease above or below the decompressed level, and comorbid conditions are the strongest predictor of clinical outcomes after decompression for spinal stenosis, or at least the strongest predictor of complications. So in this, the preferred answer is improved clinical outcomes in both pain and function at 4 years. There were a number of answers across the board. There are a number of good studies, and you really do need to be familiar with the SPORT trial, that do show that there are improved outcomes. So worse clinical outcomes, definitely the wrong answer. No difference in clinical outcomes at 4 years is not the right answer. Both pain and function are better at 4 years. Okay, another stenosis question. A 62-year-old female has a decompressive laminectomy for spinal stenosis and symptoms of right leg pain. A preoperative sagittal MRI is shown in figure A. Following surgery, she reports no significant improvement in her right leg pain. What is the most likely cause of her residual pain? So just a little bit about stenosis, the complications and failure. Complications in stenosis surgery increase with age, blood loss, and with number of levels fused. So the older the patient, the bigger the operation, the higher the complication rate. In a study by Carrion where they looked at laminectomy and fusion in an elderly patient population, they found death in 2%, major complications in about 20%, including infection in as high as 10%, and a number of minor complications. Failure of surgery for spinal stenosis is a function of a number of things that may be inadequate. If the patient never gets better, if the patient tells you in the recovery room and in the hospital the first day and on their first visit at a week or 2 weeks, my leg pain never got any better, then they were inadequately decompressed. And that can occur if it's central stenosis, lateral recess stenosis, or foraminal But they will complain early on, I've got a problem. If you fail to adequately stabilize the patient, or if they're unstable, that may present early on, but more likely will present a little bit farther down the road, a couple of months later, 3 months, 6 months, 12 months. If they have recurrence of their stenosis, they'll usually be happy for a while, and then sometime after 6 months, a year, down to many years down the road, their stenosis may recur. And with transition syndrome, similarly, they'll do well for a while, usually at least a year. But a year later, 2 years later, 5 years later, 20 years later, they'll present with transition syndrome. So the patient who doesn't get any better initially has inadequate decompression. And the correct answer would be residual foraminal or residual stenosis. A recurrent disc herniation, this patient doesn't really have a disc herniation, so that really wouldn't be probably the right answer. And segmental instability is a reasonable consideration. Usually, this patient does have a very slight spondylo, but this patient's probably going to get better if you did a laminectomy alone with this little bit of a spondylo. Her problem would be she might develop trouble down the road if she were unstable. During lumbar decompression at L4, L5, which of the following decompression techniques will destabilize the spine and require an L4, L5 fusion? So posterolateral fusion, the indications are either pre-existing segmental instability, which may be a condition like spondylolisthesis, isthmic spondylo, degenerative spondylolisthesis, and I've bolded that and underlined it because it is on almost every exam. You're asked about degenerative spondylo and the fact that you fuse if you're going to operate with degenerative spondylo. Degenerative scoliosis is usually an indication for fusion. Instability on flexion extension x-rays, indication for fusion. Or you may create surgical instability, and that would include cases of a total laminectomy with a pars fracture. If you've resected more than one total facet, so greater than 50% of both facets, or certainly the facet on both sides, then you have created instability, and that's an indication for fusion. A repeat laminectomy, for many of us, is an indication for fusion because in a repeat laminectomy, by definition, you have to take extra bone out circumferentially to get at the normal dura safely. And this extra bony resection frequently will either thin out the facets or lead to a pars fracture, and that's why many times, or for most of us at least, a fusion is part of revision laminectomy surgery. So the preferred response here, and almost all of you got it, is number 4, bilateral resection of the L4 inferior articular process. You have completely destabilized the spine if you do that, most times if you do that, it would have been inadvertent, I would assume, but still can happen, and that would be an indication for fusion. Okay, a 75-year-old woman presents with low back pain that radiates down her left leg. She prefers to stoop over the shopping cart whenever ambulating. Classic spinal stenosis. She also has a broad, unsteady gait and recently has noted difficulty picking up small objects and buttoning her shirt. An MRI of the lumbar spine shows degenerative spondylolisthesis with mild to moderate stenosis. What would be the next management plan? Well, this elderly woman has signs and symptoms of cervical myelopathy, and you'll hear a lot about that later in the webinar tonight, but the symptoms include axial neck pain, which may or may not be present, diffuse non-dermatomal numbness, tingling, burning in the extremity, Lermite's sign, and occipital headache. The extremity symptoms include weakness, subjective weakness, and they'll tell you about decreased manual dexterity, although many times you have to ask. They have trouble buttoning buttons. They have trouble with fine motor function. They may tell you they have trouble using chopsticks if you ask them about it, manipulating fine objects. In the lower extremity, they'll describe gait instability. They may even tell you that they bump into walls sometimes or they're clumsy on their feet. And that doesn't usually occur. In fact, that almost never occurs with lumbar spine problems. Lumbar spine problems do not create problems with balance or instability with walking. Gait changes in cervical myelopathy are the most important clinical predictor, and they may also have weakness and then the physical exam findings of cervical myelopathy. So in this patient, the preferred response is number 4. She has signs and symptoms of cervical myelopathy, and you need to know if that's present. If it's present, A, given the fact that she's already got gait changes, she really probably needs a neck operation first before you do anything for her back. And B, you need to be aware of it because you have to be very careful when you position a patient prone for lumbar spine surgery if they have significant cervical stenosis. So you would not, as tempting as it was for some of us, you would not go ahead with your lumbar spine surgery or even lumbar treatment. You need to evaluate the cervical spine first. Okay. A dural tear occurs during a routine lumbar laminectomy for spinal stenosis. A watertight repair is subsequently performed. How will this affect the patient's postoperative care and ultimate clinical outcomes? The reported incidence of dural tear or incidental durotomy is anywhere from 1 to 10%, depending on who you read, what the indications for surgery are, if it's a revision surgery, etc. The most important thing, if you're asked about it on a test, is the first step is always watertight repair. You don't accept anything short of watertight repair, and of course on an exam that's easy to do. Adjuncts to achieving watertight repair and to treating this include a good, tight, deep fascial closure. You can supplement your repair with biologic fibrin-type glue. Some of us like drains. I usually put a drain in. Some people feel you shouldn't have a drain. Bed rest is recommended anywhere from no bed rest from some authors to as much as 3 days, but not beyond that. If you have recurrent CSF leakage after a dural tear that either you didn't recognize or you repaired it and leaked anyway, the placement of a subdural drain for 5 days is an accepted and appropriate first step in management of recurrent drainage after CSF leak. What this question is asking about and what's been written up in a number of studies is if you look at large groups of patients, the results of the subgroup of patients who have an incidental durotomy are basically the same as those who don't. In other words, you can come out of the operating room and tell the family and tell the patient after a dural tear, you know, we got to watch this closely, but on the whole, this does not compromise the same good result that we should get. So the preferred response is number 3. The clinical outcome will not be affected. Basically, there's not an increased risk of wound infection or really anything else. They don't need to be on 7 days of bed rest. You might use a couple of days of bed rest, and they don't need to be on extended antibiotics. Okay. A 47-year-old male underwent an L4-L5 posterior lumbar decompression and fusion with instrumentation. At the 6-week clinical visit, he complains of pain in the region of his wound. On physical exam, there is wound erythema but no exudate. Laboratories show an elevated sed rate, 78 millimeters per hour, a white count of 11.2 thousand. An MRI is performed and shows a fluid collection dorsal to the thecal sac. What is the most appropriate next step in management? I'm told that the caps are up 1-0. Okay, so in cases of post-op infection, we see this in 1% of open discectomy cases, more when the microscope is used. Typically, the patient will present 2 to 4 weeks post-op with severe, unremitting low back pain. They may present with low-grade fever and a low-grade elevation of the white count. MRI with gadolinium is the diagnostic test of choice. The next step is needle biopsy, although we treat patients empirically for a post-op discitis, even if the biopsy is negative. In instrumentation cases such as this, the incidence of infection goes up anywhere from 2 to 6% and as high as 10% in some trauma series. Usually the patient will present with early wound drainage and wound healing problems. Laboratory values include usually a markedly elevated sed rate and a mildly elevated white count. MRI and CT may show a fluid collection and may be labeled as having an abscess. The treatment for a postoperative infection with instrumentation is aggressive surgical debridement. In almost all cases, in early wound infection, you can retain the hardware. Aggressive debridement with either delayed primary closure or either primary closure, and then prolonged antibiotic therapy. So in this case, the preferred response is surgical debridement followed by delayed closure and retention of the instrumentation. So to differentiate that from number 3, usually you did not have to take the instrumentation out. You can make a case, a number of you answered number 1, you could make the case for a CT-guided aspiration, culture it, and wait and see what it grows. Chances are, with this clinical picture, even with negative cultures, you'd wind up operating on them. And certainly if the cultures are positive, that would not be definitive treatment. Okay, a patient presents with severe multi-level spinal stenosis scheduled to undergo decompression and fusion from T12 to L4. Both pedicle screw length and diameter are measured preoperatively. Which of the following pedicles would be templated for the smallest diameter screw? So pedicle anatomy. The diameter of the pedicle changes as we go up and down the thoracic spine. The smallest pedicles in the thoracic and lumbar spine are seen between T4 and T6, and then the pedicles get gradually bigger and bigger and bigger until they're really quite big between T10 and T12. They then drop down in size again at L1, they get a little bigger at L2, and then they assume their nice big lumbar size at L3, L4, and L5. The pedicles between T1 and T3 are actually fairly big as well. So T4 to T6 are the smallest, and T10 through T12 are really pretty big. The angulation in the lumbar spine goes from anywhere of 12 degrees of medial angulation at L1, increases to about 35 to 40 degrees at L5 and S1. In the thoracic spine, there is no medial angulation throughout the thoracic spine except in those nice big upper thoracic pedicles where they actually do angulate medially anywhere from 10 to about 25 degrees. And the sagittal angulation in the lumbar spine, the pedicles are parallel to the superior end plate, and in the thoracic spine they angulate down caudally about 10 degrees. So our answer here is L1. That's the smallest of these pedicles. And this is just pure memorization, but it is something you might be expected, you might reasonably be expected to know. And yeah, the smallest L1, a number of you thought it was T12, but remember T12, T11, they're really pretty big. L1 is the smallest pedicle, at least of the options that were given. Okay, a 62-year-old female presents with 1 year of severe back and bilateral buttock pain. Her symptoms are worse with walking and improve with sitting. She now finds it difficult to walk even small distances. 6 months of non-operative management include physical therapy, oral medications, epidural corticosteroids, and injections have failed to provide lasting relief. Flexion extension x-rays are shown in figure A and B, sagittal and axial MRI. So she has a degenerative spondylolisthesis at L4, L5 here, a partially sacralized L5, and a moderate degree of stenosis. So degenerative spondylolisthesis occurs because of degeneration of the disc and facet. The subluxation usually is of L4 relative to L5. Risk factors include blacks, women, people with diabetes, and oftentimes you see people with a sacralized L5. And basically they present with signs and symptoms of lumbar spinal stenosis, and in the at the L4, L5 level, you get to traversing or L5 nerve root in the lateral recess. So in degenerative spondylolisthesis, the stenosis is most dramatically lateral recess stenosis. Non-operative treatment includes the standard for spinal stenosis, and surgery. Again, if you're going to operate on somebody with degenerative spondylo, you decompress them and you fuse them. So the correct answer here is number 5, L4, L5 laminectomy with partial facetectomy and foraminotomy, instrumented posterior fusion. It's well accepted in the orthopedic literature that the results of surgery with fusion are markedly better than without fusion, so that it is absolutely testable. You will almost certainly be asked this question, and you will be expected to know that if you operate on a degenerative spondylo, you should fuse them. A 69-year-old female presents with worsening bilateral buttock and leg pain, worse with prolonged standing, improves with sitting. Her symptoms have worsened to the point that it is now difficult for her to walk small distances. Physical exam shows weakness of EHL. An MRI is shown in Figure A. Non-surgical management has failed to relieve the patient's symptoms. What is the most appropriate next step in management? And this is just a little bit more of the same. Degenerative spondylo non-operative treatment modalities include NSAIDs, physical therapy, weight loss, bracing, epidural steroid injections, transforaminal nerve blocks, and the steroid injections do in some people relieve the symptoms. If the patient hasn't gotten better, and if the symptoms have persisted, certainly for more than 3 and certainly for more than 6 months, and if they're bad enough, and if they want to do surgery, surgery is the appropriate treatment. And the sports studies tell us that the results are usually pretty good. The presence of a progressive neurologic deficit would be a more compelling indication for surgery, and you do see that occasionally, and then failed non-operative treatment. And again, the right operation for a degenerative spondylo is fusion. So the preferred response here, number 4, laminectomy with posterior instrumented fusion. An ALIF, a few of you answered that. That's not really first-line treatment. I know some people may do it, but the standard answer is laminectomy for the severe stenosis, which we see here, which you're not going to address with an ALIF, and a posterior fusion. Okay. Studies have shown a direct relationship between pelvic incidence and isthmic spondylolisthesis, suggesting that pelvic anatomy has a direct influence on the development of this condition. Which angle in Figure A through E best illustrates the measurement of pelvic incidence? This is an increasingly important measure, angle if you will, and one that you may well be expect that you could be tested on, at least knowing what the definition of pelvic incidence is and what its significance is. So pelvic incidence is calculated by drawing a line perpendicular. First you draw a line parallel to the superior end plate of the sacrum. Then you drop a perpendicular to that line from the midpoint of the S1 superior end plate. And the angle between that line and a line from that reference point to the center of the femoral heads is your pelvic incidence. And the pelvic incidence, the average is about, I think, 48 degrees. The higher the pelvic incidence, the more off balance the patient is one way of thinking of it, in the sagittal plane. And a high pelvic incidence, greater than 68.5% in a couple of studies, correlates strongly with a higher degree of spondylolisthesis. So you do need to know how to, what pelvic incidence is, what that angle is, and what its significance is. It really correlates with higher degrees of slip when it's a high pelvic incidence. And so the preferred response is number 2. You can see that angle drawn here, the line to the femoral heads, which is not always so easy to see, and then the perpendicular to the midpoint of the S1 superior end plate. A 12-year-old gymnast has had progressive low back and buttock pain, refractory to conservative management for 2 years. I don't see the MRI here, but I'm going to tell you that it's a high-grade isthmic spondylo that this kid has. Surgical management with reduction of L5 on S1 would most likely, if there's a complication, lead to which of the following neurologic complications? So the surgical indications for pediatric spondylolisthesis include a slip greater than 50%, a progressive slip, or persistent pain, and in my practice at least, persistent pain. If they're functional, if they're able to go to school, but they still have a lot of back pain, I would wait at least a year to operate in an adolescent. If they have the so-called listhetic crisis where they're bedridden, they can't even go to school, if you can't get that under control in 2 to 3 months, that's an indication for surgery. The options include a pars repair, which is typically reserved for defects from L1 to L4, an in situ posterolateral fusion, which is an acceptable option for lower grade slip, the Myerding 1 and 2, and an L4 to S1 posterolateral fusion for higher grade slips beyond 50%. Reduction is a controversial procedure. There's no clear-cut guidelines for when it's indicated. The advantages are it can restore more normal sagittal alignment and reduce lumbosacral kyphosis and maybe protect the upper lumbar spine. The cons are there's a risk of significant complications, including most commonly an L5 root injury, sometimes also S1, sexual dysfunction, catastrophic neurologic injury, and there's also a failure rate pulling out of the screws. So it is a surgery that is fraught with a fairly high complication rate. So knowing that L5 is the root at risk, what is the right answer? Which of these would be an L5 finding? Not a patellar reflex, not hip flexion. It's dorsiflexion of the DIP, which is your EHL. That's a classic L5 motor. So the preferred response is number 3. Ankle plantar flexion is, remember, typically an S1 motor with a little bit of L5, but EHL is the L5 motor. Okay, in adult patients with scoliosis, the severity of the symptoms correlates with which of the following variables? So a little bit about adult deformity. Residual adult idiopathic scoliosis is the result of untreated adolescent scoliosis. And then what you see commonly is degenerative adult deformity, or de novo or degenerative scoliosis, defined as a progressive deformity either from degenerative changes, iatrogenic, maybe paralytic or post-traumatic. And the pathoanatomy is, in degenerative scoliosis, is asymmetric degeneration of the disc and or facet joints, which leads to the scoliosis, the rotation, oftentimes sagittal plane abnormalities as well. The most reliable predictor of clinical symptoms is loss of sagittal plane balance. Those are the patients who can be most predicted to have pain. So in this, the preferred response is number 2, sagittal imbalance. I have seen some places that people say coronal imbalance, but I think it's widely accepted that sagittal imbalance most closely correlates with the severity of symptoms. Does anybody have any questions?
I'm going to assume that you guys can hear me unless I see otherwise in the chat room. Thanks to Derek Moore for inviting me to do this. Certainly, this in conjunction with the Miller Review course is a very powerful thing, and be able to look at questions is very powerful. I'm going to go through this quite quickly, and I think that you are going to have these slides available later on as well for review. So first topic is ankylosing spondylitis. A 32-year-old man presents with low back pain, hip pain, gradually worsening over the past year. He reports the symptoms are worse in the morning. Radiographs are shown here below. Laboratory studies show a positive HLA-B27. What additional finding will help confirm the diagnosis? It's an AP radiograph of the pelvis, and what you should be focusing on is the sclerosis that's seen at the sacroiliac joint on both sides. So ankylosing spondylitis is one of the HLA-B27 autoimmune diseases. HLA-B27 is also seen in readers. It's also seen in psoriatic arthritis. So it's not necessarily definitively ankylosing spondylitis. The bony manifestation that we'll show you on the boards and on the in-training is probably going to be twofold. They usually show the sacroiliitis, which is here, as I pointed out before. They will also show a deformity of the spine and a flexion deformity of the spine. And the question later on is going to review that. And there's a very characteristic appearance of the spine with ankylosing spondylitis that you have to be aware of. The 3 diagnostic criteria in general for ankylosing spondylitis, HLA-B27 is one of them, bilateral sacroiliitis is another, and uveitis is plus or minus, and uveitis is inflammation of the eye. The symptoms are typically stiffness and pain, and here you see somebody with the chin-on-chest deformity. This is classically how they would appear, and you will probably see this on the in-training as well, and if you see that, that's ankylosing spondylitis. Because of the ankylosis, they can have limited chest wall expansion, they can have decreased spine range of motion, and this is what I was talking about before in the radiographs on the spine. It's a very classic appearance called the bamboo spine. You don't necessarily have to know what the word syndesmophytes are, but marginal syndesmophytes is commonly talked about. And what that means is on the margin where the annulus is, there's calcification. You can see that on the lateral view, right where the annulus is. It does not extend beyond the vertebral bodies. It sits within the annulus, and because of that, the spine has this scalloping and squared off look and looks like a bamboo. Classically called a bamboo spine. And I'll show you a differentiation between this and another disease later on, but this is classic ankylosing spondylitis, and I think you should burn this picture into your mind as ankylosing spondylitis. This is the classic appearance of somebody's neck with ankylosing spondylitis. Once again, very similar to the lumbar spine. There's obviously autofusion, but it's got this bamboo appearance where at the disc levels you have fusion at the annulus. So the answer in this case is uveitis. Remember the three things to remember: HLA-B27 diagnostic criteria. The next diagnostic criteria is going to be the ankylosing spondylitis, and of course the third is plus minus uveitis. And it looks like most of you chose that. Next question: a 69-year-old man fell on ice on arrival to the emergency room. He has a 2-centimeter laceration on the back of his head. He has neck pain, but he's A&O to time. He has a normal neurological exam. The cervical and lumbar radiographs are shown. No evidence of fracture seen on x-ray. What is the next step in treatment? And the figures are A, B, and C. What they're trying to get you to see here is that in A and B, there's obviously this ankylosing spondylitis type picture, and in C, you can see a cervical spine. You don't see the complete cervical spine, meaning you do not see all the way down to C7, T1. In addition, you can see that there's ankylosing spondylitis. The one thing I would advocate for, and this is with any type of trauma, if you are shown a radiograph of the cervical spine and it does not include down to C7, or they only show you part of it, often they're trying to get you to say repeat imaging of the cervical spine because you may be missing a facet dislocation or a fracture down lower in the cervical spine that can't be seen. In the setting of ankylosing spondylitis, the spine is rigidly fused. Because of that, there's a mechanical lever arm, and there's a very high rate of cervical spine fractures, often occult, meaning you can miss them. So if you see an ankylosing spondylitis patient with neck pain in the setting of trauma, I would certainly consider getting a CT or MRI scan to make sure the patient does not have a fracture. In addition, there is a 75% neurological involvement, and it's typically from an epidural hematoma. And these patients can progress, so you have to watch these patients very carefully in the setting of cervical spine trauma, because even small forces in the setting of an ankylosed brittle spine can lead to a fracture. So the answer is obtain a CT scan of the cervical spine because you do want to rule out fracture, and most of you did choose that. Next question is question 27. A 61-year-old man with ankylosing spondylitis falls. He hits his forehead while getting out of the shower. On arrival to the ER, he has neck pain. He has a normal neuro exam. A CT scan shows a non-displaced extension type fracture of the lower cervical spine, and they're already telling you that this patient has a fracture of the cervical spine. He's treated with a cervical orthosis. He's admitted for pain. 7 hours later, he has paresthesias in the upper and lower extremities. Examination shows weakness in the upper and lower extremities. So now he's got neurological findings. He has a 3+ out of 5 ankle dorsi, ankle plantar flexion. An MRI scan is performed emergently, probably because of the progressive neurological deficit. It's shown in figure A. What is the most appropriate next step in management? It's a little bit of a hard picture to see. There's no question you can see that there is mass effect on the spinal cord, and they're already telling you it's ankylosing spondylitis, so right away you're thinking possible epidural hematoma. You are thinking increased chance of neurological compromise. So in ankylosing spondylitis, what are the indications for surgery? And this is an overarching theme in the in-training and in the boards. Anytime they tell you there's a progressive neurological deficit, that patient needs an operation. In general, anytime they tell you that there's spinal cord compression or there's signs of myelopathy, upper and lower extremity involvement, gait disturbance, they're trying to push you towards something surgical. For an ankylosing spondylitis patient, the typical surgical approach is a posterior laminectomy because it is typically associated with an epidural hematoma. And you can decompress the cord posteriorly, and multi-segment fusion for stability in the back going to the front of the spine would probably not provide enough segments of fixation. If they show you this patient and there's no trauma, and they're trying to get you to say, how can we get this guy to look straight forward, the answer is going to be posterior pedicle subtraction osteotomy or some kind of posteriorly based wedge procedure. So you take out a wedge, you can bring their head back, and you can fuse them in place. The two things that have been asked in the past on the in-training is that sometimes these surgeries are done in the sitting position. There can be an increased chance of venous air embolus because they're sitting and the air rises through the venous architecture. And there's an increased risk of venous air embolus also with a patent foramen ovale. Those have both been tested in the past. So the correct answer, posterior cervical laminectomy and fusion with instrumentation. Once again, most of you did select that. Some of you selected anterior cervical fusion. Once again, there's a large hematoma that has to be decompressed. There's large lever arms. It requires multi-segment fixation as well as fusion, which is often best done from the back. Next topic, a 73-year-old gentleman. He has chronic back pain, neck pain. A lateral cervical radiograph has shown what is the most likely diagnosis. So this is distinctly different than what we saw previously. Previously, there's ankylosis for AS within the disc space at the margin, and there's that bamboo spine. Here you see flowing ossification anterior to the vertebral body, anterior to the disc spaces. So this is DISH, which is diffuse idiopathic skeletal hyperostosis, and I put a picture of DISH up here, and I put a picture of AS down here so you can look at the difference. Typically, it's found incidentally. Some of the possible sequelae is dysphagia, difficulty swallowing, because the bone here can actually compress against the esophagus. And you can also get, similarly to AS, cervical spine fractures because of long lever arms, even from minor trauma. How do you differentiate it from AS? They're non-marginal, so these are not on the margin of the disc space. They're outside of the disc space, and they're flowing, and they're at 3 consecutive levels. No involvement of the SI joints. Patients have pain and stiffness. Like I said, definitely discovered incidentally often. In general, do not treat these patients with surgery unless, once again, they have a fracture or progressive neurological deficit. And here's an example of a fracture. Correct answer is DISH, diffuse idiopathic skeletal hyperostosis. Many of you got that correct. Some of you chose ankylosing spondylitis. And some of you chose ossification of the PLL. The posterior longitudinal ligament, remember, is posteriorly, and you probably missed this shadow of bone. But now you know the difference between AS and DISH. Next is burst fracture in a neurologically intact patient with the injury pattern shown in figure A and B. What is the advantage of surgical treatment compared to early mobilization in a TLSO? There's obviously a fracture in the vertebral body here. It's hard to tell if it's a burst or what kind of posterior component there is in terms of bone, but they show you a CT scan. You can see clearly bony retropulsion into the canal. So remember, there are 3 columns of the spine. This is the knees classification very briefly. There's the anterior column, which is the anterior 2/3, the middle, which is the posterior 1/3 of vertebral body, and posteriorly, which is posterior to the PLL and all of these posterior structures. A burst fracture, by definition, is injury to the anterior and middle column. So the anterior and middle column. It's typically axial, and it's typically compressive in nature in terms of the loading aspect of the trauma. So it's a compressive force down. And there's been a lot of research and literature recently on the PLC, which is the posterior ligamentous complex, that may or may not show up on the in-training or boards. You should know that the posterior ligamentous complex, which is basically all the ligaments in back, can fail, and if they fail, the mechanism of failure is going to be in tension. CT is going to show retropulsion of bone into the canal typically, and you can get an MRI. The MRI is done to look at the neural elements. The MRI is also done to evaluate the injury to the posterior ligamentous complex. In general, for the in-training, burst fractures should be treated non-operatively with TLSOs, especially in somebody that's neurologically intact and mechanically stable. If they show you something that looks big and bad, there's lots of canal compromise, retropulsion, but yet the patient is neurologically intact and it's a mechanically stable fracture, the answer is non-operative with bracing. The retropulse fragments do heal over time as the patient is braced. I think for the in-training, the absolute indications, once again, progressive neurological deficit, whether it be motor or bowel bladder function, a fractured dislocation, or translational injuries, and progressive kyphosis, meaning if you get an x-ray and you get another x-ray 6 weeks down the road and there is severe kyphosis over time, that is also an indication for surgery. There's some controversy in terms of what the best operative treatment is, whether or not anteriorly, posteriorly, etc. I don't think they would make you choose. I think the literature is too split on this. However, regardless, I would always pick an answer that contains some sort of decompression in it, because remember, for the boards, they're going to say it's somebody with neurological compromise, and if there's neurological compromise, you need to do a decompression, whether or not it's from the front or from the back, and you will always need to do a fusion with instrumentation and stabilization. So look for the answer that says decompression, anteriorly or posteriorly, followed by a fusion. In a neuro-intact patient, remember that operative treatment leads to similar outcomes compared to non-op. There have been multiple studies that basically look at burst fractures that don't have a horrible amount of instability. Patients do not have neurological deficits. And in fact, some of the studies show that patients have increased disability with operative treatment. So I think that in general, in the absence of neurological deficits, they really are going to push you towards non-operative treatment. So the answer here is no advantage, equivalent clinical outcomes. Most of you did choose that. Next question, in patients with a stable thoracolumbar burst fracture, no neurological deficits, operative treatment has what long-term outcome? So they're telling you that it's stable, they're telling you there's no neurological deficits, and once again, like I said, there can be increased disability and complications with operative treatment. This is a question that I included because I like the question because it talks about surgical management of a burst fracture. I don't think it was on your exams. 26-year-old gentleman, L1 burst fracture, a car accident, initial presentation, he was neurologically intact, treated in a brace. In the last 2 days, increasing difficulty voiding, perianal sensation, weakness, what's the next appropriate step? So right away you know increased neurological deficit means that this patient needs an operation, and like I said, if they need an operation, they need a decompression. So there are only two choices with decompression, number 3 and 5, and like I said, they have to be stabilized, and only number 5 includes stabilization. So right away you know increased neurological deficit means that this patient needs an operation, and like I said, if they need an operation, they need a decompression. So there are only two choices with decompression, number 3 and 5, and like I said, they have to be stabilized, and only number 5 includes stabilization. So the correct answer is anterior decompression strut grafting instrumentation. Next topic is a chance fracture. 32-year-old gentleman presents to the ER, has a motor vehicle accident. A radiograph is shown in figure A, and a sagittal and axial CT are shown in figure B and C. What is the most likely mode of failure of the posterior column? Remember, we talked about the posterior column being everything posterior to the PLL. This is an X-ray, definitely shows that there's fracture of vertebral body. The CT scan suggests that there's fracture of vertebral body, there's retropulsion of the bone, but I want you to notice this crack in the spinous process posteriorly. And in the axial image, there's definitely bone within the canal. The first thing to know about a chance fracture is a flexion distraction injury. It's typically a seatbelt injury, so the car accelerates, it stops, you flex forward. There's an injury to the anterior, middle, and posterior column. The anterior column, because of the seatbelt anteriorly, fails in compression, and that is the mechanism. And the middle and posterior columns, which are here, fail in tension. So the anterior column is compressed, and the posterior column fails in tension. There are two types. There's a bony and ligamentous chance fracture. A bony is fracture to the posterior elements. A ligamentous injury or ligamentous chance is injury to the posterior ligaments. You can get an X-ray or a CT. The CT can show fracture of the posterior elements, and the MRI is for evaluation of the neural structures as well as the ligaments. And here you can see that there clearly is disruption of the spinous processes in a bony chance. In general, these patients can be treated non-operatively with bracing and a TLSO and hyperextension to close down the fracture. It's typically in somebody that is neurologically intact and mechanically stable. If there's a minimally displaced bony chance with adequate reduction and they're neurologically stable, I think they're pushing you towards non-operative management. If there's, once again, progressive neurological deficit, if there's kyphosis over time, or if there's a very displaced ligamentous fracture or a ligamentous chance injury, I would treat that operatively. I think they would probably focus on progressive kyphosis and neurological deficit. So the correct answer here, remember the posterior column fails in tension. That is the correct answer. A lot of you chose compression. The anterior column fails in compression. The posterior fails in tension. Next topic is thoracic disc herniation. A 47-year-old gentleman presents with back pain of 2 weeks duration. He denies night sweats, fevers, or weight loss, so you're not thinking infection. He has symptoms in a dermatomal distribution along the rib cage on the right. On physical exam, he has mild paraspinal tenderness, normal patellar reflexes, normal muscle strength in the lower extremities, and a normal gait. So they're trying to tell you that neurologically this person is normal, does not have cord compression, at least from a exam standpoint. And an MRI shown figures A and B, what is the appropriate step. They don't really tell you what level this is in the thoracic spine. Clearly there's a disc herniation here. You can see the cord here. And on the axial, there's a fragment of disc. And yes, there is some cord compression, so it's important to know in the vignette that the patient doesn't have symptoms of cord compression, even though here there is some cord compression on the MRI scene. So thoracic herniated disc, uncommon. They can be posterolateral, foraminal, central, basically similar flavors to what the lumbar disc is that Bill reviewed. Symptoms can be axial back pain. They're basically two flavors, and I don't think they're going to overlap them on the boards. I think you're going to clearly see somebody with radicular pain, so compression of the nerve that's going to cause pain along the intercostal region, or compression of the cord. As I said, cord compression is going to cause lower extremity weakness. Nothing in the upper extremity. Remember, this is below the cervical spine, so lower extremity weakness, sensory changes, bowel bladder dysfunction. That is going to be the key when you see a thoracic disc, is differentiating between just something radicular with intercostal pain versus somebody that really has progressive problems from spinal cord compression. So localized tenderness, myelopathic signs and symptoms, once again, hyperreflexia, clonus, gait instability, motor deficits. These are all things associated with spinal cord compression. Remember, an MRI can have a high false positive rate. Just because they show you somebody with a thoracic disc doesn't mean it has to be symptomatic. You have to go on the clinical vignette and read their physical exam and read their signs and symptoms. For the in-training, I would never operate on asymptomatic cord compression, meaning if they had no symptoms but it looks bad, I wouldn't operate on it. And I would not operate on nerve compression. So if they just have intercostal pain and the rest of their neurological exam is normal, I would treat it conservatively. Physical therapy, NSAIDs, bracing, I would not pick surgery. So the answer in this case is physical therapy and NSAIDs, because the vignette tells you that there is no signs of spinal cord compression. There are no symptoms of cord compression. Let's see, some of you picked surgical decompression. Once again, without signs of Progressive neurological deficit without issues in lower extremity function and only pain, I would not pick something surgical. Next question, a 29-year-old male presents with numbness, tingling in the lower extremities, gait instability for 2 weeks duration. Physical exam shows brisk patellar reflexes. So they're trying to get you to think that this person has cord compression, has myelopathy. MRI shown in figure 8. What is the most appropriate first line of treatment? What's interesting is this MRI could look like the prior MRI as well, but now they're telling you that this patient has significant gait instability, which indicates spinal cord compression. So once again, absolute indication for surgery is progressive neurological deficits / myelopathy. What are the surgical techniques? In general, do not pick something that is posterior only. You cannot retract the cord. There are no nerves here, so you can't do a laminectomy, retract the cord, and then take the disc out. So they're trying to get you to say one of two choices, either a transthoracic discectomy anteriorly, so go from the anterior approach and you can take the disc out anteriorly, and that's, as you can imagine, good for a central disc herniation, or you can do a costotransversectomy, transpedicular resection, meaning take down the pedicle, take down some of the rib, and come far laterally, come underneath the cord and resect it. But do not pick something straight posteriorly, and in general, an anterior approach is preferred. Anterior discectomy is the answer. 54% chose that. 19% chose physical therapy. So remember, gait instability indicates cord compression. When they say gait instability, progressive weakness, motor deficits, they are pushing you towards surgery. So it's either 4 or 5. Some people answered 4. Cannot do a laminectomy. That's a posterior only approach. And as I said, posterior only approaches for thoracic discs are contraindicated. Next topic is called Aquinas syndrome. 51-year-old gentleman with a pacemaker reports difficulty with urination, numbness in the bilateral buttock. Symptoms began 12 hours ago. What is the next step in management? They're trying to get you to think that this is Cauda-Equina syndrome. Remember, the Cauda-Equina are all the nerves that drape down below the conus. Typically, Cauda-Equina syndrome is from a large disc herniation. You have to know the symptoms of Cauda-Equina syndrome. It is one of the few surgical emergencies in spinal surgery. If you miss it, it's a problem. So you have to know the signs and symptoms. Lower extremity pain, sensory motor loss in the lower extremity, and as Bill presented, both of these can happen with a radiculopathy as well. You really focus on saddle anesthesia, which is numbness towards the buttock, and this is the big one, bowel and bladder symptoms. They are probably going to tell you that a patient has difficulty urinating and they have loss of bowel control. So look for those key things, bowel, bladder control. When you do a physical exam, there's decreased rectal tone, decreased perianal sensation. Obviously, you need an MRI to evaluate the neurological compression, and if you cannot get an MRI, i.e. somebody that has a pacemaker, then you get a CT myelogram. This is absolutely urgent and emergent in terms of the studies in somebody that has bowel and bladder symptoms. Non-operative treatment is not going to be the answer in somebody with bowel and bladder dysfunction. It's always going to be operative. Urgent surgical decompression within 48 hours. This has been tested, leads to two things: bowel bladder function that gets better, and motor and sensory function that gets better. So once again, bowel and bladder function, motor sensory function, and this is a surgical emergency. The surgical technique, Bill described it earlier, would be a discectomy procedure. I don't think they would show you somebody with instability, etc. Bowel bladder dysfunction is atypical with things like degenerative spondylolisthesis and lumbar spinal stenosis. That's degenerative in nature. It's typically more with a discectomy. I think that's what they would show you. Answer is CT myelogram, because they did mention difficulty with urination, so already you're thinking Cauda-Equina syndrome, and 96% of you got it correct. Epidural steroid injection is never the answer. Next topic, spinal epidural abscesses. 31-year-old active IV drug abuser reports worsening gait instability for the last 4 days. Physical exam shows weakness in the upper and lower extremities. A sagittal MRI shown in figure A. What is the most appropriate step in management? When you look at this figure, the first thing you see is that there's destruction of the disc space, there's some swelling anteriorly, there's involvement posteriorly, and there's a mass collection behind the bone. And there's clearly spinal cord compression, and immediately, because of the worsening gait, increasing neurological deficits, you're already thinking surgery. So what is a spinal epidural abscess? It's pus that's between the dura mater and the surrounding tissue. This is a collection of pus that's here. It's often associated with discitis, osteomyelitis, and we will review that later. So often you'll see destruction of the disc space along with it, inflammation of the soft tissues, and contiguous fluid with the disc space as well as the abscess. A third of patients will have neurological symptoms. Risk factors, if they tell you the person's immunodeficient, diabetic, IV drug abuser, you automatically know that that the person could possibly have an infection. The pathogen Staph aureus, as in most things in orthopedic, is going to be the most common pathogen. Gram-negative infections such as E. coli with urinary tract infections, etc., are also very common. These patients are sick and they have pain. They can have radiculopathy or myelopathy, and remember, this has been tested before, the preoperative neurological deficit is an indicator of clinical outcome. You can get labs, white blood cell, ESR, CRP, MRI with gadolinium is the treatment of choice. It shows the extent of the abscess, whether or not there's associated osteomyelitis, whether or not the disc space is involved. You can evaluate the neurological structures. Certainly in somebody that does not have a severe neurological deficit can be braced with long-term antibiotics. You need to find the organism and you need to diagnose it early if you're going to treat it non-operatively. Indications for surgery in general, I think for the in-training, they're going to show you somebody with a neurological deficit, possibly persistent infection or progressive deformity or instability. How you do it, I think the way you should think about it is very straightforward. If the compression is from the back, do it from the back. If the compression is from the front, do it from the front. In general, hardware infusion for stability is okay in the setting of infection. Some of you may think, well, you can't instrument the spine in the setting of infection. Yes, you can. So for posterior abscesses, posterior decompressive laminectomy. Anteriorly, you obviously cannot get to this abscess without going through the disc space, and because you take the disc space, you are going to have to bone graft it and fuse it, and you would use post-operative antibiotics. So the answer is, because they have progressive neurological deficits, you need surgery. So the only surgery answer is one or two. So you either do it from the front or from the back, and because the abscess is anteriorly and it involves the disc space as well, I would certainly do that from the front. 15% answer CT guided biopsy. It's not a bad thought, but remember, for the in-training and for the boards, with progressive neurological deficit, you know that patient has to be decompressed anyway. While you're in there, you are going to obtain cultures of the abscess, you are going to go through the disc space, and you'll be able to identify an organism that way. Next topic, pyogenic vertebral osteomyelitis. A 60-year-old diabetic woman presents to the ER, chief complaint of focal low back pain, 5 days duration. Radiographs show diffuse lumbar degenerative disease. There's mild pain with palpation. Routine urine analysis by the ER physician shows a UTI, so you know she's infected, you know she's diabetic, you're thinking infection. Her white blood cell count is 12.6, so slightly elevated. Her ESR is 58, so definitely elevated. What's the best choice in management? Vertebral osteomyelitis, similar to spondylolisthesis, it's basically an infection of the disc and infection of the bone. Staph aureus is the most common, as is the overarching theme with infections. Someone with IV drug abuse, you can think Pseudomonas. With sickle cell, think Salmonella. and gram-negative infections with respiratory tract and GU infections. Remember, IV drug abuser, diabetes, immunodeficient, somebody with a chronic systemic infection, UTI, bowel infection, etc., can possibly see the disc space and cause vertebral osteomyelitis, and they'll usually put that in the question stem. Some will have neurological symptoms either because there is an epidural abscess, and certainly some because of bony destruction can have compression because of bony instability. There will be pain in these patients. A third will have fevers. Look for elevated labs. The best test for vertebral osteomyelitis, this is the board answer, MRI with gadolinium. It's sensitive and specific. What you are looking for is destruction of the bone, replacement of the bone marrow with edema, and changes in the disc space and end plate with contrast enhancement of the surrounding tissues, disc, paraspinal, epidural space. Vertebral osteomyelitis looks angry. You have to differentiate it from tumor. In general, with tumor, it is not going to cross the disc space, and you're not going to see a lot of disc or a lot of end plate erosion with the tumor. It's mostly localized to the vertebral bodies. So in this patient who had systemic illness, UTI, diabetes, elevated ESR, you're thinking that she has vertebral osteomyelitis. You do not want to miss infection. And so I would choose MRI of the lumbar spine with and without GAD in order to look for vertebral osteomyelitis. That is the best study. 33-year-old gentleman with a history of IV drug abuse presents with low back pain, increasing intensity. He is neurologically intact. So remember, this patient is neurologically intact. Lab studies have slightly elevated white blood cell count, 11,000. Elevated ESR, so you're thinking infection because they have IV drug abuse and elevated ESR. Blood cultures are performed and the blood cultures are negative. So that's very important. Blood cultures are performed and they're negative. There's a radiograph shown in figure A, MRI T1 and post-GAD T1 weighted images shown in figure B. What's the initial management? So we look at the MRI and here's a great picture of infection with gadolinium. This is a T1 weighted image. Remember in T2, the CSF would be bright. This is dark. You can see there's some destructive process within the bone marrow happening. And this is really the money picture, which is after gadolinium and fat suppression, meaning it makes the fat dark and the gadolinium is lighting up granulation and edema. You can see destruction of the disc space. You would not see that in tumor. There's involvement of the bone. There's marrow replacement. Look anteriorly. And there's all this stuff anteriorly, so this definitely looks angry. The x-ray I don't think is that helpful. So how do you treat vertebral osteomyelitis? The boards is trying to get you to think that you need to identify the organism and you need to eliminate the infection. You need to treat any neurological deficits and, as usual, maintain spinal stability. So remember, only 33% will have a positive blood culture, as in the question stem. The question stem said that they had a negative blood culture, so it shouldn't be surprising to you. Remember, the goal of treatment is to identify organisms, so if you cannot get a blood culture and you don't have an organism, CT-guided biopsy is the board answer. 75% of the time, that will provide you with a diagnosis. Non-operative treatment, certainly in somebody that doesn't have severe neurological deficits and you do have an organism, you can brace them, use long-term antibiotics, and that certainly can be successful. Operative treatment, remember, the one overarching theme is going to be neurological deficit. How do you treat these people operatively? In general, you have to debride the infection, debride the disc space, so that is typically an anteriorly based procedure. So if you debride the disc space and you go in there or you take out bone, you do have to graft it and you can fuse them for stability. And that would be the answer. Once again, just like epidural abscesses, it is okay to instrument in the setting of infection. So CT-guided closed biopsy is the answer because the blood cultures are negative. If the blood cultures are negative or are positive and you have an organism, you don't need to identify the organism, so you do not need a CT-guided biopsy. Many of you chose Staph aureus specific IV antibiotics. They're trying to get you to think, do not treat it until you really know what it is, therefore CT-guided biopsy. Next topic is compression fracture. 71-year-old female has no significant medical comorbidities, presents to the ER after a compression fracture of L2. The patient has moderate back pain, is neurologically intact. Radiographs of the entire spine reveal an L2 compression fracture, 30% loss of vertebral body height, 15 degrees of kyphosis. What is the most appropriate management for this patient? So, osteoporotic compression fractures are typically seen on X-ray. It's a wedge-type appearance. Remember, it's the most common osteoporotic fragility fracture. The World Health Organization of osteoporosis is T is less than 2.5. Remember that. A compression fracture, they're always going to tell you it's an older patient, and they're going to tell you the older patient had a relatively low mechanism injury and has back pain. They're going to have back pain at the area of the fracture. Neurological compromise is rare. You can see it on X-ray. If you want to look at fracture chronicity, you can definitely get a MRI, and you can see edema within the bones, and if there's edema, obviously it's an acute fracture. You need to tell the primary care doctor for treat for osteoporosis. This is a very hot topic, particularly for the in-training and for the boards. There's a 20% increased risk of a secondary fracture, so that's why it's important to treat the osteoporotic fracture. And the greatest risk of another fragility fracture is a prior fracture. Both of these have been tested in the past. And the one thing you have to be thinking of is ruling out cancer. In older patients, these can be metastatic lesions, they can be myeloma, and they can definitely get compression fractures as a result of weakening of the bone. Almost all vertebral fractures, compression fractures in osteoporotic patients are treated non-op with or without a brace. Bed rest is never indicated. I think for the in-training, operative treatment is really going to be rare. The only absolute indication, I think they would show you somebody with progressive neurological deficits or instability, which is exceedingly rare with a compression fracture. A lot of you in your training probably are seeing vertebroplasty and kyphoplasty. It's controversial. The American Board of Orthopedic Surgery does not recommend for vertebroplasty, and the results of kyphoplasty are also controversial. I don't think that would ever be the right answer, so I would not choose vertebroplasty or kyphoplasty. So this is an older patient. There's no neurological compromise. They're telling you that's a relatively stable fracture. Bed rest, like I said, never the right answer. The answer is oral pain meds, TLSO, progressive increased activity, and it looks like 96% of you got that correct. Okay, that's it.
Spine. So with that, Brian, why don't you turn your mic off so we can get rid of this echo. I'm going to close you out. All right, so this we'll go into the last portion of the talk. My first topic is that of cervical myelopathy. Cervical myelopathy is probably the most commonly tested concept along with spinal cord injury in the cervical spine. I actually think focusing your efforts on studying the cervical spine is fairly strategic and high yield, just because they usually ask questions on either cervical myelopathy, cervical radiculopathy, or spinal cord injuries. So if you really know those three topics alone well, plus or minus odontoid fractures, then chances are you're going to get a good large percentage of these questions right. So let's go into the first question. All of the following clinical signs are characteristic of an upper motor neuron disorder except. So you got to recognize that upper motor neuron disorders include cervical myelopathy and spinal cord injuries. And you need to be very familiar with the symptoms and physical exam findings of cervical myelopathy. So the typical symptoms of cervical myelopathy include numbness and tingling in the extremities. So keywords you want to be looking for in the question stem include bilateral or non-dermal tomo. Other symptoms include decreased hands dexterity. So keywords you want to be looking for in the question stem include difficulty buttoning shirts or dropping objects. And finally, these patients usually have some component of gait instability, and the way this might be described in the question stem is that they are frequently bumping into walls or have difficulty walking up and down stairs. Cervical myelopathy can be diagnosed on physical exam alone. You want to look for decreased hand function and weakness. One thing you want to look for is interosseous wasting, as you see in this clinical photo on the right. The other thing you want to check for is if they have a positive grip and release test. And this is when they have difficulty opening and closing their hands rapidly. You want to look for the classic signs of upper motor neuron spasticity. This includes hyperreflexia, Hoffman signs, clonus, and Babinski test. Remember, for clonus, you really want to see sustained clonus or greater than 4 beats for it to really be positive. Again, gait instability is very sensitive in these patients. I always have them walk toe to heel. If they are myopathic, they are going to have difficulty walking toe to heel. So going back to the question, all of the following clinical signs are characteristic of upper motor neuron disorders except, so we just went through that. Classic symptoms of cervical myelopathy and upper motor neuron disorders are spasticity, muscle weakness, exaggerated deep tendon reflexes, or sustained clonus. So the only one that is not typical is fasciculations. Only 54% of you got that question right, so I'm a little surprised by that. Next question, which of the following procedures is contraindicated in a patient with 11 degrees of flexible cervical kyphosis and multi-level stenotic myelopathy requiring decompression? So to get this question right, you have to understand the concept of cervical lordosis versus kyphosis. So in the normal cervical spine, you can see that the spine is actually lordotic in the cervical spine. This means that the spinal cord actually drapes right within the center of the spinal canal. Now you can imagine if a patient becomes kyphotic, what happens is the spinal cord actually gets pulled anteriorly, so it starts draping across the anterior compressive elements. And you can see that here in this illustration. So you can imagine if you go ahead and do a posterior laminoplasty or posterior decompression alone, this actually does very little to actually decompress the spinal cord if it's draping over those anterior compressive elements. For this reason, whenever somebody has a kyphotic deformity, you want to go anterior first. This can either be an ACDF or a multi-level ACDF. It can be a corpectomy. It can be a hybrid construct, or it can be a 2-level corpectomy. The thing you want to remember is if you ever do a 2-level corpectomy from the front, you need to stabilize this posterior with a posterior fusion. The reason for that is if you don't, there's a very high percentage that these grafts actually dislodge and can lead to catastrophic complications, including death. Going back to the question, which of the following procedures is contraindicated in a patient with 11 degrees of flexible cervical kyphosis? The proper answer to this is laminoplasty. 87% of you got that right. Now some people might ask, why isn't laminectomy and instrumented fusion contraindicated? And this illustration shows that if a patient has a flexible kyphotic deformity, it's possible if you do a posterior spinal fusion, you can actually correct that deformity and then go ahead and do a decompression. This most likely will not appear on this test. The next question, a 60-year-old female presents with progressive loss of ability to ambulate and dexterity problems with her hands. 6 months ago she was able to walk with a cane, but now has difficulty with ambulating with a walker. She also reports difficulty with her hands and needs assistance with eating. Physical exam shows 15 degrees range of motion from neck flexion to extension. Radiographs, CT, and MRI are shown in figure A, B, and C. What is the most appropriate treatment? So if you look at these x-rays here, you can see that this patient has a rigid kyphotic deformity. Looking at your CT scan, you can see she has kyphosis from the C2 to C7 angle, and she also has a local kyphosis angle. Looking at your MRI, you can see that she has CSF effacement at this level here, which is, you can see this is the bottom of C2, so this would be C3-4, C4-5, and C5-6. So she has a significant spinal cord compression at least 3 levels. So whenever you think of cervical myelopathy and treatment of cervical myelopathy, you just want to ask two questions. The first question is the patient kyphotic? And the second question is, how many levels of compression are there? They like to ask these cervical myelopathy treatment questions, and they usually give several answers. One answer is either going to be an anterior alone procedure. Another answer is either going to be a posterior alone procedure, which would probably include a laminoplasty, or the last option that they're going to show is an anterior and posterior procedure. If you ever see laminectomy alone on this test, do not answer that. There's really no indications for a laminectomy alone, and the reason for that is the risk of post-laminectomy kyphosis. So going back to this case, we have a patient. If you draw her C2 to C7 Cobb angle, you can see she's kyphotic, greater than 10 degrees of a kyphosis, and she has greater than 3 levels of compression. So by looking at this kind of grid here, we can see that she's kyphotic and has 3 levels of compression, and therefore you're going to want to go anterior and posterior. Again, in patients who are kyphotic, you have to go anterior first to correct her deformity and bring that spinal cord away from those anterior compressive elements. Looking at this x-ray here, that's what we did here. We did an anterior and posterior procedure. And you can see on your final x-rays where by doing this anterior procedure, we brought her back to neutral, which is really your goal in the anterior procedure. So going back to this question, again, we had a patient with cervical kyphosis of greater than 10 degrees, and they're asking what is the proper treatment. Again, you want to be, well, in addition, she had 3 levels of compression, so you're going to be looking for a both anterior and posterior procedure, and option 5 was the only one that had both an anterior and posterior procedure. 74% of you got this correct. Next question, a 35-year-old man complains of clumsiness when buttoning his shirt and frequent episodes of falling when ambulating. Further workup reveals congenital cervical stenosis with spinal cord compression. Because of his young age, a posterior laminoplasty is performed. Which nerve root is most likely to be adversely affected following surgery? So you need to know your complications of cervical surgery. The 4 main complications you need to know are C5 palsy, recurrent laryngeal nerve injury, Horner syndrome, and hypoglossal nerve injury. C5 palsy is usually associated with a posterior procedure and is notoriously associated with a laminoplasty. These other complications are usually associated with an anterior procedure, and we'll talk about that a little bit later. So going back to this question, it's a 35-year-old. He had a laminoplasty. What is the most likely nerve root that's going to be negatively affected by surgery? The proper answer to this is the C5 nerve root, so the correct answer is 4. 89% of you got that correct. Right now we're going to move on to spinal cord injuries. This is another topic that's very commonly tested. First question, which best describes a patient's functional level with a complete C5 spinal cord injury? So they like to ask questions on classification of spinal cord injury. So you need to know your functional levels and you need to know your ASIA classification. So when you think of a spinal cord level or an injury level, it's the last functional level. So if a patient is a C5 injury level, that means that the last functioning levels are deltoid and biceps. That means he can abduct his shoulder and he can flex his elbow to bring his hand towards his mouth. But because he doesn't have C6, he cannot extend his wrist and he cannot supinate his wrist, so he's unable to bring his fingers to his mouth. This is very different than a C6 level where he does have wrist extension and he does have wrist supination, so he can actually feed himself. And this explains the significant difference between a C5 level and a C6 level. C6 levels, they can feed themselves, they can usually live independently, and they can use a manual wheelchair. That's a manual wheelchair. This is very different than a C5 level where these patients usually can only use an electric wheelchair and cannot use a manual wheelchair. So going back to the question, which best describes a patient's functional level? If he's a C5 level, the best answer here is 2, electric wheelchair with hand control. I was surprised if most of you got answer 1, which is electric wheelchair with head or chin control only. That would describe somebody who has an injury level or a level of either C1 to C4. Question: following an acute spinal cord injury, a patient presents with systemic hypotension and relative bradycardia. His bulbar cavernosus reflex is present. This is characteristic of what type of response to a spinal cord injuries? So you need to be able to differentiate spinal shock from neurogenic shock from hypovolemic shock. Spinal shock and neurogenic shock are both characterized by bradycardia and hypotension. This is very different than hypovolemic shock, where patients have tachycardia and hypotension. The way to differentiate spinal shock from neurogenic shock is that in spinal shock, the bulbar cavernosus reflex is absent. For the purpose of this test, when a patient has neurogenic shock, usually his bulbar cavernosus reflex is present. Going back to this question, they're asked, this is a patient who has a systemic hypotension and relative bradycardia, so you want to be thinking either neurogenic shock or spinal shock. They say his bulbar cavernosus reflex is present. Therefore, you're thinking neurogenic shock. Correct answer is answer 3. Next question. A 23-year-old man falls down the stairs while intoxicated and is brought to the emergency room the following morning. On physical exam, he has no motor function in his upper and lower extremities. Sensory exam shows diminished but present sensation in his perianal area and his lower extremities. Reflex exam shows his bulbar cavernosus reflex is intact. So he's out of spinal shock. His bulbar cavernosus reflex is intact. Imaging studies are shown. How would you classify this according to the ASIA classification system? So it's very likely that you're going to be asked a question on spinal cord injuries, and you're going to have to classify it based on the ASIA impairment scale. The ASIA system is very simple. You just want to write down on a piece of paper A, B, C, D, E. Just remember, E is normal, strong as an Asian elephant. A is absolutely no motor or sensory. C is halfway in between, or 50% of the muscles are grade 3 or above. Level D is greater than 50% of the muscles are grade 3 or above. And B, just remember, barely anything, meaning sensory only. So going back to this question, again, we have a spinal cord injury. Bulbar cavernosus reflex is intact, so we know he's out of spinal shock. He has no motor function, but he does have some sensory. So again, this is ASIA B, barely anything, no motor, sensory only. 85% of you got that question correct. Next question, a 79-year-old male falls sustaining a hyperextension injury to his neck. A lateral radiograph, CT scan, and MRI are shown in figures A through C. On motor exam, he has 3 out of 5 strength in his deltoid, elbows, and wrist flexors and extensors. So he has 3 out of 5 strength in his upper extremities. He has 4 out of 5 strength in his hip flexors, knee extensors, and ankle dorsiflexors and plantar flexors. So he has greater weakness in his upper extremities than his lower extremities. Sensation is preserved in both his upper and lower extremities. Injury to which of the following tracts contributes greatest to this motor, his motor functional deficits? So this is a classic presentation of central cord syndrome. You need to be familiar with central cord syndrome. It's something you see frequently in your clinical practice, and it does show up on these tests. So it's usually seen in an elderly patient with an extension injury to the neck. It's due to canal stenosis due to compression of the spinal cord between the anterior osteophytes and the posterior ligamentum flavum. What happens is that this preferentially compresses the central portion of the spinal cord. And if you look at your lateral cortical spinal tract here, you can see that the tracts for the upper extremities, more distal in the hand, even preferentially so, is more medial than your lower extremities. And this explains why when these patients have a a central cord syndrome, that it preferentially affects their upper extremities and preferentially affects their hand function. So when you think of central cord syndrome, think of clumsy hands in an elderly patient. In terms of the prognosis of this condition, they usually have full functional recovery, except they're usually left with some clumsy hands. They usually do gain their lower extremity function and their ability to ambulate. So going back to this question, injury to which of the following contributes greatest to his motor functional deficit in a patient with central cord syndrome? So the proper answer there would be lateral cortical spinal tract. I forgot to review the imaging studies here. Here you just have a spondylitic spine, and you can see that he has some effacement of CSF. This is typically what you see on an MRI in a patient with central cord syndrome. You just see some compression with CSF effacement, but usually you don't see any obvious cord compression or any myomalacia. So now we're going to move on to cervical radiculopathy. First question, we have a 33-year-old male presents with neck pain and left arm pain. He denies symptoms in his right arm. Based on MRI image shown, what findings can be expected on physical exam? So they love to ask about cervical radiculopathy and the physical exam. So you need to know the symptoms and physical exam findings of cervical radiculopathy. Symptoms, the keywords you want to look for in the question stem is that it's usually unilateral, and it often improves when patients raise their arm. A lot of times patients report that when they're driving a car, they actually hold their seatbelt to keep their arm up in the air. On physical exam, you need to know your levels. So C5 is deltoid and biceps. C6 is sensory to the thumb, brachioradialis, wrist extension and supination. And as you know, C7 is innervation to the fingers, second, third, and fourth fingers, and triceps and wrist flexion and pronation. Reflexes aren't very helpful in the evaluation of cervical radiculopathy. They're usually normal or might be decreased. Provocative tests that you want to be aware of, be aware of the Sperling test, and then also know that one provocative test is that you can actually, if you're suspicious of cervical radiculopathy and you're trying to differentiate it from a peripheral process such as carpal tunnel syndrome or cubital tunnel syndrome, you can actually lift their arm in the air, and sometimes this relieves their symptoms. And this actually has been tested in the past. So going back to the question, based on the MRI findings, you see on the MRI this patient has a C4-5 disc. You got to remember that it affects the nerve root below. So a C4-5 disc is going to affect the C5 nerve root. So you're going to be looking for weakness to shoulder abduction and elbow flexion. So the proper answer is going to be answer 2. Okay, next question. A 59-year-old complains of acute pain radiating from the neck down the right upper extremity. Physical exam demonstrates right arm triceps weakness, decreased triceps reflex, and diminished sensation to the middle finger. A cervical disc herniation will most likely be found at what level? So again, you need to know your physical exam for cervical radiculopathy. This patient had sensory changes to the middle finger, so the third finger. It decreased triceps, so you know that this is a C7 radiculopathy. So if a patient has a C7 radiculopathy, where are you expecting your disc herniation? Again, it affects the nerve root below in the cervical spine. So for a C7 radiculopathy, you would expect a disc herniation at the C6-7 level. So going back to the question, a disc herniation would be expected at which of the following levels? And that would be C6-7. Next question, a 52-year-old woman underwent a C5-6 ACDF for cervical radiculopathy through a left-sided approach 2 years ago. Radiographs are shown in figure A. She has altered voice since the operation. Recently, the patient has developed myelopathic symptoms, including gait instability and dexterity problems with her hands. An MRI shows an adjacent level midline disc herniation at C6-7 with cord compression and myomalacia. Laryngoscopy of the vocal cords demonstrates abnormal function of the vocal cords on the left-hand side. What is the best next step in management? So the situation here is we have a patient who had a previous ACDF. She's developed adjacent level disease and progressive myelopathy, and the source of compression is anterior, so we know we need to go anteriorly to do the operation. So again, you need to know your complications of cervical spine operations. You need to know C5 palsy, which is associated with posterior procedures. And then the anterior complications you need to be aware of is recurrent laryngeal nerve injury, Horner syndrome, and hypoglossal nerve injury. So in this patient, she has difficulty swallowing. So we know that, and one of her vocal cords is not working. So we know that she has a recurrent laryngeal nerve injury. So you need to be familiar with this complication. Recurrent laryngeal nerve injury leads to vocal cord paralysis, as well as change in voice and altered swallowing. You should be familiar with the anatomy of the recurrent laryngeal nerve. On the left-hand side, it comes down here, wraps around the aorta, and ascends to the tracheoesophageal groove. On the right-hand side, it's slightly different. Again, it's a branch off the vagus nerve. Then it wraps around the subclavian artery, and then comes back and actually crosses the surgical field and enters the tracheoesophageal groove at around C5-6. And this is why people, traditionally have said that the chances of injuring the recurrent laryngeal nerve are decreased if you go in on the left. However, that's never been substantiated in the literature. So in terms of management, if you have an acute recurrent laryngeal nerve injury, you just want to watch it for 6 weeks. If it doesn't get better, then you want to send them to ENT. More importantly, in this question is the issue if a patient has a prior recurrent laryngeal nerve injury documented by laryngoscopy and you need to do an anterior procedure. The question is, do you go on the same side where they have a pre-existing recurrent laryngeal nerve injury, or do you want to go to the contralateral side? Now, patients do fairly well if they only have a unilateral nerve injury. They usually just have some mild difficulty in swallowing or a slight change in voice. They do not do well if they have a bilateral recurrent laryngeal nerve injury. They're not going to be able to talk. They're not going to be able to swallow. They're not going to be happy. So going back to this question, she has a previous recurrent laryngeal nerve injury on the left. We need to do another anterior procedure. So in this situation, we want to go back in on the same side. So we want to go in on the left-hand side. The last thing you want to do is go in on the other side, which is her right side, and injure her remaining functioning recurrent laryngeal nerve. The next topic, odontoid fractures. The risk factors for non-union with non-surgical treatment of the fracture shown in Figure A includes all of the following except. So, odontoid fractures are commonly tested. You need to know your 3 different types of odontoid fractures. In terms of thinking about treatment, it's very useful to break it down into actually 4 parts. You want to break it down into type 1 odontoid fractures, type 2 in the young, type 2 in the elderly, and type 3 odontoid fractures. Treating type 1 and type 3 are very simple. You want to treat them in an external orthosis or a halo. Just remember, if the patient's elderly, you never put him in a halo. Treating type 2 odontoid fractures is a little more complicated. Again, you want to break it down into type 2 young and type 2 elderly. The reason it's more complicated is because in type 2 odontoid fractures, 1, you can't put elderly patients in the halo, and 2, because there's a high non-union rate. Literature shows it's about 30%. So you need to know your risk factors for non-union. They include greater than 5 millimeters of displacement, angulation greater than 10 degrees, posterior displacement, age greater than 40, a fracture gap greater than 2 millimeters, or treatment delays. So going back to our question, they're asking what are the risk factors for non-union? They're asking risk factors for non-union in a type 2 odontoid fracture include all of the following except. So displacement of more than 5 millimeters, this is a risk factor. Angulation greater than 10 degrees, this is a risk factor. Delay in treatment greater than 3 weeks, this is a risk factor. Age greater than 30, no, that's incorrect. It would be age greater than 40, so the correct answer is 4. Next question, in elderly patients with type 2 odontoid fractures, which of the following treatment modalities has the highest morbidity and mortality? Again, going back to our grid, when you're looking at type 2 in elderly, there's basically 2 treatment options. Non-operative, which would be a soft cervical collar. Again, you never put an elderly patient in a halo, versus surgery. Typical surgery in this would be a posterior C1-2 fusion, although you could do an anterior screw osteosynthesis, though I think it's unlikely that that is going to appear on this test. So going back to the question, what treatment option is associated with the greatest morbidity and mortality in elderly? The proper answer would be halo vest immobilization, or answer 3. 87% of you got that correct. So next topic, cervical facet dislocations. This has been tested in the past. They usually test about how you treat these. So the question is, awake and cooperative patient. Again, he's awake and cooperative, presents to the emergency room with the injury shown in the CT scan. Prior to the CT, the patient had an ASIA impairment scale of E. So again, you got to know your ASIA impairment scale. E, strong as an Asian elephant, which is normal. So this patient, prior to going to the CT, had a normal exam. Upon returning, he had an ASIA impairment score of D. So his neurologic status is actually declining. And they're asking, what is the most appropriate next step in management? So looking at the CT scan, we see you have about 50% subluxation of the vertebral bodies. And if you look posterior, you can see he does have this facet. Excuse me, got to use this here. He does have this facet dislocation here. Again, this is your 50% subluxation. So cervical facet dislocations, it's essentially a spectrum of disease that goes from unilateral facet dislocations, which are usually or often missed on x-rays just because you only have 25% of subluxation. These classically present with a monoradiculopathy, meaning it only involves one arm. This is different than a bilateral facet dislocation, where you usually have 50% subluxation on the radiographs. This is exemplified in this image here. These patients usually have more severe neurologic deficits and spinal cord injuries. In addition, facet fractures can either occur independently or in association with these facet dislocations. So they like to ask about treatment of cervical facet dislocations, and they can ask about 2 types of treatment. First, they can ask, what is the initial step in treatment, or the first line of treatment? And then they can also ask, what is definitive management? So to determine what is the first line of treatment, you're basically going to be choosing do you send this patient to an MRI, or do you go emergently or straight to closed reduction? And to answer this question, you want to ask 2 questions. The first question, is the patient alert and oriented? If a patient is obtunded or intoxicated, you cannot do an emergent closed reduction. So if a patient is not alert and oriented, you always want to go to the MRI. Assuming that he is alert and oriented, the next question you want to ask is, does he have serious neurologic deficits? If the answer is no, and for instance he has a unilateral dislocation and just has a radiculopathy in one arm, then you just want to go to the MRI. However, if he does have serious neurologic deficits, so the patient is awake, alert and oriented, has serious or progressive neurologic deficits, this is when you want to go straight to the emergent closed reduction. And that has been tested in the past. That is the first line of treatment. They might ask you, what is definitive management? And what you need to remember is everybody that has a cervical facet dislocation on this test has to be stabilized with some type of operation. You can either do it anterior with an ACDF, or you can do it posterior with a posterior fusion. The answer to this question is determined by whether the patient has an anterior disc herniation or not. So, after you get your closed reduction, if you do it, you still always want to get an MRI prior to going to surgery. On that MRI, you're going to look for whether the patient has an anterior disc herniation. If he does have an anterior disc herniation, then you want to go ahead and do an ACDF. If he doesn't have an anterior disc herniation, then you actually have a choice between whether you go anterior or posterior. This is just kind of a simplification of what I just discussed. So again, if the patient is alert and oriented or has severe neurologic deficits, first you want to go straight to emergent closed reduction and then get an MRI. This is in contrast to if a patient has altered mental status or mild symptoms, then you just want to do the MRI first. Always get the MRI before you go to definitive management of stabilization, and that is going to help you determine whether you go anterior or posterior. All right, so going back to our question. So again, we had a wake and cooperative patient. We had a bilateral facet dislocation with progressive neurologic deficits. Again, you ask those two questions. Is he awake and cooperative? The answer is yes. Does he have severe neurologic deficits or progressive neurologic deficits? The answer is yes. So you want to go to immediate closed reduction and fracture followed by surgical stabilization. 77% of you got that correct. So next topic, atlas fractures and transverse ligament injuries. Figure A shows the coronal and axial CT of a 72-year-old male that suffered a fall from significant height. Which of the following radiograph measurements would best indicate disruption of the transverse ligament? So looking at your coronal CT scan, or actually let's look at the axial CT scan first. What we are looking at here is the posterior arch of C1, and you can see he has two fractures in the posterior arch, and then he also has a fracture line or a bilateral fracture is the anterior arch. So this is your classic Jefferson fracture. On your coronal CT, you want to look for displacement of the lateral mass coming over the C2 body here. So you want to know the anatomy of that atlantoaxial joint. You need to be familiar with the transverse ligament. It's the major stabilizer of the C1-2 segment. And you can see this is several different illustrations that just depict that ligament. It basically travels from the lateral mass of C1 and then stabilizes the dens against the anterior arch of C1. This is another image looking at your C1 ring from above. Here you're looking at the dens, which is C2. And again, you see that the transverse ligament connects the lateral masses of C1. So these different lines show the different fracture patterns that you can have of the atlas. The most classic is the Jefferson fracture, where you have a fracture of the posterior arch and the anterior arch. Now what you want to be thinking here is if you have an injury to the transverse ligament or not. Now if you think of lateral displacement of the lateral masses, you can imagine that if the transverse ligament is intact and connecting them, you're not going to be able to have lateral displacement, or at least not much of it. So that's why the key question you want to ask is, does the patient have an intact transverse ligament? And the way you answer that question is by looking at your lateral mass displacement. This is both best viewed on your open mouth odontoid. What you want to do is measure the overhang of the lateral mass, which is this structure here, and see how much it overhangs over C2 here. So assuming that this was 3.5 millimeters, you want to add these both together. And if this distance is greater than 8.1 millimeters, then that's indicative that you do have a transverse ligament injury. Again, the transverse ligament would be connecting these lateral masses right here. And if you injure it, you can have, displacement of the lateral masses and instability. So going back to the question, we had a patient with a fall from height with a Jefferson fracture. Which of the following radiographic measurements will best indicate disruption of the transverse ligament? The proper answer is going to be combined lateral mass displacement of greater than 8.2. or answer 4. So we're running out of time, so I'm going to go quickly through these last ones. They do like to ask about halo immobilization. In this question, with halo immobilization, the anterior pin should be placed in which of the following regions in figure A to avoid injury to the supraorbital nerve and optimize stability? So for halo immobilization, you need to know the technique in adults. In adults, you place 4 pins at 8 inch-pounds of torque. In children, you do twice as many pins at half as much torque, so it would only be 4 inch-pounds. There is a safe zone. The safe zone is a 1 centimeter region that is in the lateral 2/3 of the orbit, 1 centimeter above the supraorbital ridge, and below the equator. So you can see on this illustration here, the reason you want to have it on that lateral 2/3 is because you do have the supraorbital nerve that ascends in the medial 1/3, which you want to avoid. So again, what is your safe zone? You want it to be in the lateral 2/3 of the orbit, 1 centimeter above the supraorbital ridge, below the equator here. So your safe zone is going to be D, which is answer 4. Here we have a 27-year-old male in an understrung motor vehicle accident. He was medically stabilized in the emergency room. His initial CT images are shown in figure A and B. He is neurologically intact and placed in a halo fixator prior to surgical treatment. What is the most common neurologic complication with halo traction? Here you see a patient with a type 2 odontoid fracture. You know it's a type 2 just because the fracture line is just below the anterior ring of C1. It's important to recognize that. Indications for halo as definitive management include a C1 burst fracture. We just spoke about that, or type 2 or type 3 odontoid fractures in young patients. Remember, you never place an elderly patient in a halo. Other indications are some types of Hayman fractures. Again, you want to avoid the supraorbital nerve by going into your safe zone. If you go too medial, you could injure the supraorbital nerve, and that's going to lead to a deficit in lateral eye movement. So again, the question here is, what is the most common neurologic complication with halo traction with the anterior pin? And that would be injury to the supraorbital nerve or deficit in lateral eye movement. All right, we're going to try to get through a few more topics. 60-year-old woman with rheumatoid arthritis has long-standing neck pain and new onset of difficulty holding cards in her weekly poker tournament. She does not complain of weakness, but states she has become clumsy in her old age, fumbling and dropping objects. On exam, she is hyperreflexic, but has no weakness. Radiographs show atlantoaxial subluxation. She is considering decompressive surgery, but wants to know if she will recover function. What radiographic marker may predict neural recovery after decompression? So this is a patient with rheumatoid arthritis. They have classic atlantoaxial subluxation and symptoms of myelopathy. So for rheumatoid cervical spondylitis, it's common in patients with rheumatoid arthritis. You can see it in up to 90%. There's 3 patterns of instability. There's atlantoaxial subluxation, where you have migration of the dens away from the anterior arch of C1. Other patterns are basilar invagination, which is much less common, where you can see that the tip of the dens actually migrates up into the base of the skull. And the final pattern of instability is that of subaxial subluxation. And you can see down here in the subaxial spine, you have subluxation of the vertebral bodies. They usually only test atlantoaxial subluxation. There's 2 radiographic parameters that are commonly tested. That is the atlantodens interval. Again, you want to measure the distance from the dens to the anterior arch of C1. In a normal patient, this dens abuts the anterior arch of C1. This is the ADI. The other radiographic parameter is the distance from the back of the dens to the back of the posterior arch of C1. And this is what they call the PADI, posterior atlantodens interval. This is the same term or the same thing as SAC, which is the space available for the cord. So you want to look at your atlanto-dens interval and how it changes with flexion and extension x-rays. So you always want to get flexion and extension x-rays in these patients. If you have greater than 3.5 millimeter increase, that means they're unstable, but that does not necessarily mean it's an indication for surgery. If you have greater than 10 millimeters of subluxation, this does mean that they're grossly unstable, there's increased risk of neurologic injury, and that's an indication for surgery. Now, your PADI, or your space available for the cord, remember, this is the space the spinal cord is going through, so you want this number to be large. Less than 14 millimeters is associated with increased risk of neurologic injury and is an indication for surgery. And also by the work of Bowden, if it's greater than 13 millimeters on your pre-operative x-rays, this is a very important predictor in terms of complete neurologic recovery after surgery. So again, this is just an flexion extension x-ray. Normally an extension, the dens abuts the anterior arch of C1. Here you can see that you have subluxation with flexion. So going back to our question, we had a patient with atlantoaxial instability due to rheumatoid arthritis. What radiographic marker may predict complete neurologic recovery? And as we just said, based on the work of Bowden, the best answer for that is your posterior atlanto-dens interval of greater than 13. All right, we're going to whip through this one last topic. 27-year-old female with Down syndrome presents with neck pain, progressive gait instability, and loss of fine motor dexterity in her hands. So she's becoming myelopathic. Flexion and extension radiographs are shown in figure A and B and demonstrate occipital cervical instability. When performing an occipital cervical fusion, what location of figure C is most appropriate for placement of an 8 millimeter screw? So although you rarely see it in clinical practice, you do need to be aware of occipital cervical instability. It can occur in trauma, which is very rare, but more commonly where you see this is actually in patients with Down syndrome. And I actually had a few patients referred to me where occipital cervical instability was picked up on screening x-rays, flexion extension x-rays for the Special Olympics. And usually these patients come to you and they're normal and you really don't know what to do with them. But anyhow, to measure or evaluate occipital cervical instability, you want to look at your Powers ratio. What this is looking for is essentially subluxation of the occiput on the C1 joint. So your Powers ratio is measured by measuring the distance from the anterior arch of C1 to the basion, which is point B here, and it's the ratio for the posterior arch of C1 to the epiphyseon, which is point C here. So if you look at this x-ray, look at the distance from the anterior arch of C1 to the basilon. You can see it's basion, excuse me, it's pretty small. Where an extension, you can see that the entire occiput is subluxing posteriorly. So the distance from A to B is increasing. The distance from A to B increases, and the Powers ratio is going to decrease. In this example, it's 0.766, and that's what you would expect to see when you have posterior subluxation, as we do here. Treatment for this is occipital cervical fusion. You do need to know where you can get the best purchase in the back of the occiput. Your safe zone for your screw placement is at the level of the superior nuchal line, as shown here, and within 2 centimeters of superior nuchal line, as shown here, and within 2 centimeters of midline. Going back to our question, in figure C, what is the most appropriate safe zone for placement of an 8 millimeter screw? Again, at the level of the superior nuchal line, within 2 centimeters. So the best answer would be region B, or answer B. All right, with that, we're going to end it. So Brian, if you're there, why don't you turn on your mic and your webcam? And if Bill, you're